So, good evening and a warm welcome to all the dignitaries present here. I'm Sreyoshi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event, hosted by the Indian Radiological and Imaging Association, Samrakshan, and the focus of today's session is Samrakshan Protocols. So, without any much delay, I would like to hand over this session to Dr. Akanksha ma'am. Over to you, ma'am. Please proceed.
Thank you so much, Tracy. Good evening, everyone. Namaste to all. Yet another session of Samrakshan Friday weekly webinar meetings. And today it is very special as all of us aware that FGR and complication is a major concern in our country and global south, and also having long-term complication associated with. So we are having very important topics, Samrakshan Protocol by Dr. Rijo Mathew sir, and first trimester screening for preeclampsia and FGR by Sandhya madam. And with this, all would like to call upon our expert in the Samrakshan team, founder of Samrakshan Initiative, Dr. Rijo Mathew sir, to address us. And sir is currently chairman and chief radiologist in Insta Specialty Hospital, Kochi, Kerala, and Amma Scan Center for Diagnosis and Preventive Medicine, Kochi, Kerala, and did MBBS from Government Medical College, Thrissur, University of Calicut, and BJM did MD from BJM Medical College, Ahmedabad, Gujarat, and DNB from National Board, New Delhi. Past experience, Chief Radiologist and HOD Department of Radio Diagnosis, Sunrise Hospital, and Senior Resident, Jaslok Hospital, Mumbai. And so many achievements are there. IRIA Best State Secretary Award twice in 2018 and 2021. IRIA President Appreciation Award for continuous 5 years from 2018 to 22. ICRI Award 2019 for organizing the first IREP Radiology Resident Education Program in Kochi, and ICRI guest lecture for Dr. S.K. Sharma Ultrasound Symposium in Gandhinagar 2020. And Dr. G.R. Jankaria Best Paper Award in 2021, and National President Appreciation Award in from 2018, 19, and 20. And sir is AOSR MR Safety Ambassador in 23-25, and ACSF Secretary 23-25, and member QSS Committee AOSR in 21 and 23, and also Editor-in-Chief Journal of Fetal Radiology, exclusive Editor General of Gastrointestinal Abdominal Radiology, and Reviewer Fetal Imaging and Women Imaging in IJRI, founder Samrakshan IRIA National Program to reduce perinatal mortality in India, and national coordinator, been national coordinator in 2019 to 20, and national coordinator of fetal radiology CME in 2028. 18, and Secretary IRIA Indian Radiologic Imaging Association Kerala State, member Scientific Advisory Committee in IRIA 2018, and member Career Assuring Committee IRIA, Subspecialty Head Radiology and Imaging Indian ICRI in 2018-21. Secretary Indian Multidisciplinary Society of Men's Health and Healthy Aging, and Secretary Kochi, Kerala for Radiology Education Support and Training. Thank you so much, sir, your academic enthusiasm, being with us, guiding us all the time, and so much of you are really inspiring figure to all of us. Over to you, sir.
Thank you, Agansha, and welcome each one of you for this webinar session. This is the 35th webinar session in this Friday weekly series, started during the national coordinatorship of Dr. Anjali Gupta and the joint coordinator Dr. Agansha Bagel. Both of them are doing exceptionally good work this year for Samrakshan. Throughout the country, they have channelized, they have mobilized, they have motivated more and more Samrakshan Yodhas to join the Samrakshan movement. Thank you, Agansha, and thank you, Anjali, for the wonderful activities that you are doing this year. And I think before we go into the webinar, I think there is something that we, as part of, we are not just in a movement that only goes through academics. We have got so many other, we encourage our yodhas, our warriors to showcase their talents, talents in promotion of health, the Samrakshan movement, and health education awareness campaigns, videos. And one of the wonderful videos that has been made by Dr. Nilmani Sharma from Agra, and a campaign to start in this day of Quit India movement is a FGR Quit India movement that we are starting. And I request the Shreyasi and the team to play that video, which will give you an insight into the campaign that we are starting today.
Right, sir.
FGR भारत छोड़ो, FGR भारत छोड़ो, टिंग टिंग टिंग। FGR भारत छोड़ो आंदोलन में आपका स्वागत है। कुछ ही देर में हम NICU पहुंचेंगे। 1, 2, 3, 4। अरे NICU में इतनी भीड़ क्यों है यार? डॉक्टर साहब, हम सब हैं FGR के मारे। आप ही बताओ कहाँ जाएं हम सब बेचारे। ओह अच्छा, तुम लोग ठीक से विकसित नहीं हो पाए हो और वजन भी कमजोर लगता है। क्या मतलब है आपका? मैं तो पूरे 9 महीने अपनी माँ के गर्भ में रहा हूं। अरे बेटा, जेस्टेशनल एज मतलब हाउ ओल्ड आर यू, तुम्हारी उम्र कितनी है, और ग्रोथ का मतलब है तुम कितने विकसित हो पाए हो, तुम्हारा वजन कितना बड़ा है। चलो छोड़ो, ये बताओ कहाँ अटकी तुम्हारी गाड़ी? जीन्स प्लेसेंटा इन्फेक्शन या मम्मी ने लगा दी वाट तुम्हारी? मैं हूँ बेबी नंबर 1, डेड नंबर 1। मेरी मम्मी थोड़ी छोटी, थोड़ी मोटी, हमेशा तनाव में रहती, खाने पीने का बिल्कुल ध्यान नहीं रखती, आयरन और प्रोटीन सप्लीमेंट बिल्कुल नहीं खाती, धुआं उड़ाती रहती और जाने क्या चबाती रहती। सुना है मेरी दीदी भी बहुत कमजोर थी। अच्छा, पर मैं तो बेबी नंबर 2 हूँ। मेरे मम्मी पापा ने तो मेरा पूरा ख्याल रखा था, समय से अल्ट्रासाउंड भी करवाया था, पर पता नहीं अचानक ये प्रीएक्लैम्सिया कहाँ से आ गया। काश किसी रेडियोलॉजिस्ट ने संरक्षण प्रोटोकॉल से डॉपलर स्कैन किया होता और समय पर मम्मी को एस्प्रिन लेने की सलाह दी होती, तो शायद मैं यहाँ ना होता। ओह, लगता है मेरी और तुम्हारी कहानी थोड़ी मिलती जुलती है। मैं बेबी नंबर 3 बोल रहा हूँ। डॉक्टर्स बता रहे थे कि प्लेसेंटा में ब्लड सप्लाई सही नहीं जा रहा, पर अच्छा हुआ मेरे रेडियोलॉजिस्ट ने ठीक से प्लेसेंटा चेक किया, वरना तो वो बेचारा प्लेसेंटा साइड में पड़ा पड़ा बहुत ही नेग्लेक्टेड फील करता है। खामोश, सारा शहर मुझे सिंड्रोमिक बेबी के नाम से जानता है। दिल में मेरे है छेद और बाकी भगवान ही जाने मेरे भेद। फ्री फ्री फ्री, एक पे एक फ्री, बाय 1 गेट 1 ऑफर में मम्मी ने हमें है पाया। कंजुनाइटल इन्फेक्शंस ने भी हमें थोड़ा बहुत डराया। थैंक यू बच्चों, हमें अपनी कहानी शेयर करने के लिए। हम पूरी ताकत लगा देंगे तुम्हें खुशहाल बनाने के लिए, पर सावधान, NICU के बाहर भी खतरा कम नहीं है। हैं? क्या मतलब? कहना क्या चाहते हैं आप? बीपी, शुगर, मोटापा, अस्थमा और हार्ट अटैक कर रहा है तुम्हारा इंतजार। ओह नो, व्हाई मी? पर मैं ही क्यों? जब तुम्हें फीटल हाइपोक्सिया हुआ था और एसिडोसिस हुआ था, तो बहुत सारे हार्मोनल और वास्कुलर चेंजेस हो गए हैं। सेल ग्रोथ पूरी तरीके से मॉडिफाई हो गया है। कुछ सेल्स कम हो गए हैं और कुछ इम्बैलेंस हो गए। कहीं कहीं तो जीन मॉडिफिकेशन भी हो गया है। अब हमारा क्या होगा? घबराओ नहीं, कुछ पोस्टनेटल इंटरवेंशंस बताता हूँ, उसका ख्याल रखना तो तुम स्वस्थ रहोगे। 6 महीने तक सिर्फ माँ का दूध ही पीना, थोड़े बड़े होने पर पौष्टिक आहार लेना, अस्पताल जाकर अपनी ग्रोथ मॉनिटर करवाते रहना, थोड़ा और बड़े हो जाओ तो नियमित रूप से बीपी चेक करवाना, तंबाकू बीड़ी शराब से तौबा तौबा, और नियमित व्यायाम करके मोटापे से बच के रहना। अच्छा, तो आप कह रहे हैं कि क्योंकि हमारी मम्मी बीमार थी तो हम कमज़ोर हैं, और जब हम बड़े होंगे तो हम भी बीमार होंगे, फिर हमारे बच्चे कमज़ोर होंगे। ऐसे तो चलता ही जाएगा, चलता ही जाएगा। इसीलिए बताता हूँ, थोड़ी समझदारी से हम इस चक्रव्यूह को तोड़ सकते हैं। इसके लिए हमें गर्भवती माताओं और उनके परिवार को शिक्षित करना होगा कि वे नियमित रूप से अस्पताल जाएं और अपनी जांच करवाते रहें, बीपी और शुगर को कंट्रोल में रखें, नियमित व्यायाम करें, अपना वज़न कंट्रोल में रखें और तनाव से दूरी बना के रखें। अल्ट्रासाउंड स्कैन होने पर डॉपलर स्कैन ज़रूर करवाएं, पौष्टिक आहार लें, आयरन कैल्शियम सप्लीमेंट लेना बिल्कुल ना भूलें। बच्चे के ग्रोथ के लिए प्रोटीन बहुत ही आवश्यक है, जिसके लिए आप प्रोटीन पाउडर घर में भी बना सकते हैं। उसका सामान ज़्यादातर हमारे घर में ही मिल जाता है, जैसे गेहूँ, चना, रागी, बाजरा, गुड़ और शक्कर इत्यादि। तो चलो मिलकर भारत देश को स्वस्थ और खुशहाल बनाएं। टिंग टिंग टिडिंग। इस आंदोलन से जुड़ने के लिए आपका आभार। आशा है आज का आपका सफर ज्ञानवर्धक व रोचक रहा होगा। धन्यवाद।
Thank you, Dr. Neelmani Sharma, for that wonderful video that she has made, and it has really described in Hindi or the conversation between the different babies in the ICU and NICU and the different conditions they have come out with and the importance of FGR screening with Doppler and everything that she has covered wonderfully. I think Dr. Neelmani is here. Dr. Neelmani, say hi, and we all wish to congratulate you for this wonderful.
Hello, sir.
Yeah.
Yeah,
Thank you,
thank
Neelmani.
you, sir. Thank you.
Thank you, Neelmani.
Thank you, sir. But it looks very awkward and funny to listen to your own voice. It was very funny now.
But that voice modulation and everything was superb. Thank you, Neelmani, and
Thank you.
keep on doing this. Neelmani had
Yes.
created one more video on preeclampsia earlier, and that also was a big hit. I can see that this is one of the social media the viral ones from the Samrakshan. That thank you, Neelmani, once again.
Yeah, thank
So I would request the Samrakshan Yodhas to come out with the regional videos also in other languages, also in the similar content, and to enhance the FGR Quit India campaign. Thank you very much. Agansha, can I move on to my lecture?
Yes, sir.
Okay. Can I share? Let me share my screen.
Yes, sir.
Is my screen visible?
Yes, sir.
Okay, right. So what I'm going to do for the next 30 minutes or so is to talk about the Samrakshan protocols. Why this is necessary is because ever since we started Samrakshan, I think many still are ignorant about the Samrakshan and the movement to reduce perinatal mortality in India, to reduce avoidable deaths of mothers and babies in India. But many times, many people have perceived it just as a screening program only for preeclampsia. Some have added and understood that this is a screening program for preeclampsia and FGR also, but not Samrakshan protocols are not just a screening program for preeclampsia and FGR. There are a lot of things involved in the thought process of Samrakshan and the implementation process of Samrakshan to achieve our goals to reduce the perinatal mortality, maternal mortality, etc. So this is a program that was launched in 2019. by Dr. Hemant Patel when he was during his presidential tenure, and it was implemented on ground from Sono Summit in Chennai, and we had the first CME at Indore in September 1st. That's where Dr. Lily Sharma and Agancha and all were fascinated to Samrakshan and became the Samrakshan Yodhas and the spokespersons and the leaders of it, if you look at it, after 5 years. So the core philosophy, why we focused on Samrakshan, and because India is a major contributor to the perinatal deaths, stillbirth rates, neonatal mortality, infant mortality, child under 5 mortality, low birth weight babies, the maternal mortality. 1/5 of all the pregnancies are happening in India, but we are contributing to 25% of all the perinatal statistics in whatever that I've mentioned. And we are causing a major disease burden on the fetal-maternal well-being if you consider the world statistics. So how can what can we do about it is the thought process. How can the radiologists show the commitment? That's how the Indian Radiological and Imaging Association came into this picture and initiated the Samrakshan program, which was conceived and focusing on two things, that is preterm preeclampsia and fetal growth restriction. Why did we come to that conclusion that if we focus on these two things, we can make a huge difference? And that the reason for the neonatal mortality and perinatal mortality in India, unlike in the West, is not congenital anomalies or aneuploidies. It is 43.75% cause is preterm births and complications, and 20% cause are due to intrapartum related complications or childbirth injuries, childbirth causes. So it is the congenital anomalies contribute only to 8.1% of perinatal deaths and neonatal deaths. So there is something that we need to look upon. What causes this preterm births, prematurity, the intrapartum complications, and we identified and zeroed in on two components, two factors, that is preeclampsia and fetal growth restriction. So this is very prevalent in India. India has got a very high incidence prevalence of preeclampsia. Unlike in the West, it's nearly 8 to 10%. If you take the gestational hypertension disorder, it may be much more than this 10%, and it is increasing also as the non-communicable diseases are on the high in various parts of the country. And there is no uniform distribution of this 10%. Some parts in the central India may be having even 20% or more of preeclampsia too. And similarly, fetal growth restriction also India is having a very high incidence. There is no studies that cover the pan-India perspective, but whatever studies have come out from India shows a percentage of nearly 25 to 35% of fetal growth restriction in India. And again, the low birth weight babies in India is again 30%. So that's a huge numbers of preeclampsia and fetal growth restriction and low birth weights in India. So if we can identify those mothers and babies who are at risk for preeclampsia and fetal growth restriction, can we do something? This was a thought process that we that initiated the conceptualization of the Samrakshan program. So if you look at the prevalence of low birth weight, hypertensive disorders, preeclampsia, and maternal mortality, you see that they are huge in numbers. But compared to the congenital disease anomalies, heart diseases, neural tube defects, and the aneuploidies and Down syndrome. So it is relative prevalence of adverse pregnancy outcomes in India has been contributed by low birth weight, hypertensive disorders, preeclampsia, and the fetal growth restriction. So and the comparison with the Western world is something that Dr. Praveen has highlighted this, that if you look at the numbers of preeclampsia in UK, it will be 16,560, but in India, it is 24 lakhs plus. So the first protocol for Samrakshan is Samrakshan Protocol. The first protocol is comprehensive scan. Every pregnancy scan is a great opportunity to do a comprehensive assessment for preeclampsia screening, FGR screening, anomalies, and aneuploidies, because that is what the mothers or the parents are looking at: a normal weight baby, neurologically intact baby, without any structural anomalies, without any genetic anomalies, and a safe delivery and safe motherhood. These are the things that the parents are looking for, and is it possible? In our pregnancy scans, we need to incorporate all these 4 parameters and make it a comprehensive assessment, rather than limiting ourselves to NT scan, anomaly, routine anomaly scan, growth scan, BPP, etc. And these are not the way that Samrakshan's first protocol is. It is time for us to redefine the pregnancy scans as a comprehensive assessment for all the 4 parameters of anomaly, aneuploidy, fetal growth, and fetal-maternal environment. Because Samrakshan has given the thrust and the focus to preeclampsia, which is a fetal-maternal environment disorder, and fetal growth, the fetal growth restriction, which is a fetal growth disorder. These two are the major contributors to adverse perinatal events in India and low and middle income countries, unlike in the West, where they have only 2 to 3% preeclampsia and 2 to 3% FGR. Of course, anomalies and aneuploidy screening is what the focus of pregnancy scans in India. That is important, but it has to be a comprehensive assessment pregnancy scan, where all the 4 components has to be incorporated in your pregnancy scan. So the first protocol is every pregnancy scan is a great opportunity for a comprehensive assessment of 4 important parameters: screening for aneuploidies, screening for anomalies, screening for fetal growth, and screening for fetal-maternal environment, especially preeclampsia. The second protocol, this comprehensive assessment has to be done in all 3 trimesters. We are not doing that way. We do a partial or a fragmented indications, partial scans in different trimesters, or there is a tendency by even by the government has still given only 1 pregnancy scan, 1 scan during pregnancy. But it doesn't serve any purpose. It is time for us, if you truly want to address the issues that nation is facing, this is the kind of protocols that we need to address in having in the pregnancy scans. That is comprehensive assessment in all 3 trimesters, especially the 11 to 14 weeks first trimester comprehensive screening, say 18 to 24 the second trimester comprehensive screening, and in 28 to 36 weeks the third trimester comprehensive screening. And the third protocol and the thrust that we are giving is Dopplers. Use Dopplers as the pivotal radiological biomarker in all 3 trimesters for the combined screening of preeclampsia and fetal growth restriction to identify the high-risk group of mothers and babies for preventative therapy, effective follow-up, and management. So I've shared the thrust that we need to give in the first 3 protocols. Every pregnancy scan is should be a comprehensive scan for aneuploidy, anomaly, fetal growth, and fetal-maternal environment with focus on preeclampsia. And comprehensive assessment in all 3 trimesters, first trimester, second trimester, and third trimester. We need to do all these components, all the screening for all the components in all the 3 trimesters. And Doppler is the pivotal radiological marker in all the 3 trimesters for combined screening. Now, moving on, when we started this movement of Samrakshan, Samrakshan was not just an academic program. We did the data documentation, multi-centric studies, and the publication of research papers. And one of the important papers that has come out from Guna district in Madhya Pradesh under the leadership of Lalit Sharma, the social radiologist, is the discordant dating of pregnancy by LMP and ultrasound and its implications in perinatal statistics. Nearly 15,000 pregnancies were covered, and we realized the Samrakshan study published in IGRI on dating in pregnancy found out that out of 14,701 pregnant women screened, 32% could not accurately recall their LMP. Of the remaining 10,000 who recalled their LMP, EDD by USD matched only in 70% and did not match in 30%. So roughly 50% of females do not know their LMP, or if they give an LMP, it is either going to be an under-assessment or an over-assessment compared to the gestational age calculated with ultrasound. So this is a ground reality in India. So misclassification of fetuses as term by LMP-EDD when the USG-EDD indicates that the fetus is preterm can result in low birth weights and high infant mortality, and that is a very important cause. And we decided the Samrakshan Protocol 4 is dating of pregnancy is mandatory at 11 to 14 weeks. And once an EDD is assigned, you should not change the EDD in subsequent scans. So unfortunately, different kinds of practice are still there, but it is time for us to change the dating of pregnancy at 11 to 14 weeks. And once an EDD is assigned, there is no need to give EDD in all the subsequent scans separately. The same EDD has to be followed. Coming to Samrakshan Protocol 5, screening for preeclampsia and FGR in the 11 to 14 weeks for stratification of high-risk group and to start low-dose aspirin. As we have emphasized, the importance of identifying those mothers at risk for preeclampsia is very important because of the higher incidence of preeclampsia in India. And if according to the ASPRI trial and many of the studies that has come out during the period of 2014 to 18, it has been proved beyond doubt. And we also wanted to validate whether it works for India in a large study. And in our multicentric studies also, we found out that it works in India, and in India is a country that needs to be practiced it in a big way so that the effect can make a significant difference to the perinatal statistics and avoidable deaths of mothers and babies in this country. As you all know, preeclampsia is a dreaded condition with a lot of complications for mother and child, and because even after the delivery, the mother can have long-term complications in terms of ischemic heart disease, chronic kidney disease, cerebrovascular accidents, and or even the children also can have obesity, metabolic syndrome, etc. So I'm not going to the detail of preeclampsia, but this is wonderful. During that in 2024 May, the Preeclampsia Awareness Month, one of our Samrakshan committee members and a key senior person who has done a significant work in Samrakshan is Dr. Kavita Aneja in the Samrakshan Committee. Her editorial in Hindu has highlighted the program of Samrakshan and the importance of screening for preeclampsia in all pregnancies in India. So it is essential for us to. The protocol 5 is to integrate the screening for preeclampsia at 11 to 14 weeks, and those high-risk group identified should be started with 150 milligram low-dose aspirin, and should be followed up till 36 weeks. Or 1 week before the delivery. I'm not going into the steps of this first trimester screening, as Dr. Sandhya Dhankhar, the senior Samrakshan Committee member, will be giving her talk specifically focusing on this. So there is a methodology to do this, and that she will be highlighting. I'll just glance through it, but I'm not going into the detail of it. But it is too sad. Still, we see many reports like this. When increased mean uterine artery PI without just some uterine artery PI was mentioned, measured, and somebody thought it is increased. So there is not a combined screening. There are a lot of conceptual errors that is related to not doing it in the proper way. I'm sure those who are listening will understand the right and proper way to do the screening for preeclampsia with uterine Dopplers as the pivot, serum, the mean arterial pressure, the maternal characteristics, and all this, and serum biochemistry as part of the combined screening protocol. So, and the risk can be calculated with the online FMF calculator. And those who are at high risk, with a cutoff of 1 in 150, you have to start 150 milligram low-dose aspirin at bedtime from 12 to 36 weeks, and this will reduce the risk of preterm preeclampsia by 80%, and that is something that we have proven in the multicentric studies of Samrakshan. And those in the low risk group has to be reassured and followed up at the second trimester. So this part, I'm just going, there are different parameters, the maternal demographics, maternal history has to be taken, the mean arterial pressure has to be taken, the uterine artery Doppler has to be taken, the risk for preeclampsia has to be calculated from the FMF online calculator by entering the data. the separate risk for fetal growth restriction has to be calculated. And once the cutoff is more than 1 in 150, you have to recommend and start low dose aspirin 150 milligram at bedtime till 36 weeks. And though they have to be followed up in the second trimester also. So this part will be covered by Dr. Sandhya in detail. And so the protocol number 5 was having the screening for preeclampsia in 11 to 14 weeks. This is a recent publication that has come out. We identified a high-risk group, and if they are not taking, we advised low-dose aspirin, but if they are not taking, what will happen? When they compare to the compliant group, those who are taking it regularly and those who are not taking it regularly or not even taking it, what will happen in spite of knowing that they are a high-risk group? Either they are ignorant about the importance or their doctors have not given sufficient advice. So what will happen? This is what we checked in a large series of nearly 500 cases. The high-risk pregnant women were 266, and we realized that the non-compliant group had significantly increased preterm births, stage 1 FGR, preeclampsia, and lower birth weight. So this is very important study that will tell you a good compliance for low-dose aspirin is possible even in rural populations with adequate counseling, because in Guna district, the social radiologist Dr. Lily Sharma was counseling, following it up, and having interdisciplinary interactions with the concerned people. So starting low-dose aspirin at 11 to 14 weeks for high-risk pregnant women lowered the incidence of preeclampsia, FGR, and preterm birth rates and improved birth weight in the study population. So the protocol number 6 is to have screening for not only for preeclampsia, screening for FGR too, which is often ignored now. Now, preeclampsia awareness has gone up, but screening for FGR is not being much important. And even if we recommend 150 milligram for those who are at high risk for fetal growth restriction, the some of the stakeholders are not giving much importance to that. But considering the higher incidence of fetal growth restriction and low birth weights in India, it is essential to start low-dose aspirin and other measures too in this group 2. And this is the Samrakshan Protocol 6, which includes screening for fetal growth restriction and also promoting compliance with low-dose aspirin by counseling, interdisciplinary interactions, and follow-up. So that I'll just sum up the 4th, 5th, and 6th protocol. 4th is dating of pregnancy is mandatory at 11 to 14 weeks. And once the EDD is assigned at first trimester, do not change it in EDD in subsequent scans. And what is the 5th protocol? First trimester comprehensive combined screening for preeclampsia at 11 to 14 weeks, and whoever is in the high risk group, recommend 150 milligram low dose aspirin. First trimester screening for FGR. This has to be calculated separately using the online calculator. There are a lot of confusion. That's why I'm emphasizing this particular point. Many people think it is just a preeclampsia calculator only. The second part of it is an FGR calculation. The risk, those babies who are at risk for developing fetal growth restriction can be identified at 11 to 14 weeks. And those who are at risk, we can give low-dose aspirin. Considering the larger incidence and prevalence of fetal growth restriction and low birth weight in India, in our studies, we have seen it is making a significant difference. I'll come to the results of the studies. And again, as part of Protocol 6, we have to promote compliance with low-dose aspirin by counseling and having interdisciplinary interaction. Discuss with your gynecologist who is still reluctant, or include them in the Samrakshan campaign as Samrakshan Yodhas, so that they will also follow the Samrakshan protocols. And again, you need to follow up with the patients when they come for the second trimester screening or the third trimester screening and make sure whether they are taking aspirin till 36 weeks. Coming to Samrakshan Protocol 7 is, so this is a chart of pregnancy scans at different trimesters. What are the protocols that we can follow at 11 to 14 weeks? What are the things that we are looking at? But I have shared this here to highlight the importance of screening for fetal growth restriction has to be extended into second trimester too. The combined screening for preeclampsia and early fetal growth restriction with the multivessel color Dopplers, especially the uterine artery Dopplers and umbilical artery Dopplers, has to be integrated in the as part of the Samrakshan Protocol 7. Why that is important? Fetal growth restriction is defined as the failure to achieve the endo's growth potential, and if as part of the second trimester comprehensive TIFA scan, where you're looking for the new anomalies and the second trimester genetic markers, screening for preeclampsia and fetal growth restriction with Dopplers are also very, very essential. The fetal Doppler studies, you're looking for mean uterine artery pulsatility index and umbilical artery pulsatility index. So estimation of risk for preterm preeclampsia, detection of early PE, and detection of early FGR is also very important, because in our multicentric studies, we have identified the incidence of congenital anomalies may be 3.81%. It is usually the 2.97 to 3% in most of the studies, but 3.81% in many parts of India. But that percent, we have got preeclampsia, early onset preeclampsia, in second trimester preeclampsia after 20 weeks, starting at that the incidence is somewhere around 6.61%, and the incidence of high risk for fetal growth restriction, the early onset fetal growth restriction is 6.8%. So both these numbers are higher than the incidence of congenital anomalies. So that is why this study was published, prioritizing fetal structural abnormalities over risk for preeclampsia and fetal growth restriction in the 20 to 24 gestation week assessment in India. Are we missing the woods for the trees? That means we are not seeing the real picture there. We are focusing again and again on anomalies, though they are important, but we are missing the larger picture of missing out those babies and mothers who can develop preeclampsia and fetal growth restriction and cause adverse outcomes. As part of the protocols, we have protocol number 8 is to have how to calculate the percentile, because this is many of the obstetric reports will say in weeks, this number BPD and then this weeks. They don't calculate the biometry by percentiles. That is an essential one thing, and it can be calculated using many of the ultrasound machines with different growth charts has it, or reference charts has it, or if you don't have it, you can have the online software using FMF and Barcelona to calculate the percentiles. Percentile calculation is essential for growth assessment. And again, growth velocity assessments with growth charts also are important for serial assessments to know the change in growth percentiles from the crossing centiles is something, it's a parameter that we rely upon to understand the growth pattern of the fetus. So Samrakshan Protocol 8 is all growth scans should have biometry percentiles. All growth scans should have multivessel Dopplers with mean uterine artery PI percentiles, umbilical artery PI percentiles, CPR percentiles, especially in third trimester, and the staging of FGR. Growth scans without biometry percentiles, Doppler percentiles, and without serial growth assessments are incomplete. So it is mandatory to have all the 3 parameters included in your growth scans when you assess for fetal growth restriction. The Samrakshan Protocol 9 is when you come into the third trimester, as I mentioned, the comprehensive pregnancy scans, assessment of pregnancy scans with all the 4 parameters, we have to extend it in all the 3 trimesters, including the third trimester, where the fetal Doppler studies become very, very important, because it can differentiate a early onset fetal growth restriction from late onset fetal growth restriction, and also from the small for gestational age fetus, who is a constitutionally small fetus which can go up to the normal. We can go up to even 40 weeks, can have a absolutely normal outcome. Unfortunately, the cutoff of arbitrary cutoff of fetal weight less than 10 centile was taken somewhere in the 1960s, and that has been followed before this introduction of Dopplers and this growth assessments in a proper way that we are doing now. So still we were actually misdiagnosing all these constitutionally normal fetuses as small fetuses or abnormal fetuses, and they were all they were all subjected to preterm delivery and prematurity, and this is something that should not happen. And Though the concepts of early onset and late onset fetal growth restriction is now gaining ground, many people know with Dopplers what is the difference between these two phenotypes of early fetal growth restriction and late fetal growth restriction. It is essential for us to use a multi-vessel Doppler to identify, especially the percentiles, especially the Doppler percentile, uterine artery percentile, umbilical artery percentile, and the CPR, that the cerebroplacental ratios between the MCA Doppler and the umbilical artery Doppler. And these are the criteria. Many some sessions that we had gone through this. I'm not going into the details, but this particular study that we did as part of the Samrakshan project, the color Doppler ultrasonography in the 3rd trimester of pregnancy significantly reclassifies fetal growth restriction in the Samrakshan program of IRIA in India. What we identified was there was nearly, if you take the fetal weight as 10th percentile, there would have been 20% of fetuses would have been termed as FGR. But if we integrating Doppler studies, we were able to reclassify that 8.8% as the small for gestational age, or the constitutionally small fetus whose weight is less, but there are no abnormal Dopplers. And then the rest only were actually the true fetal growth restriction. What do we mean by that is extrapolating that findings to a general population. That's a high incidence of fetal growth restriction identified this single parameter of fetal weight less than 10th centile, but without integrating Dopplers. But there is a 5 million births which were earlier classified as FGR. That would reduce to 2.8 million, and the remaining 2.2 million fetuses will now be classified as small for gestational age and can be carried up to term or even up to 40 weeks. So unnecessarily, we were subjecting these babies for preterm deliveries and prematurity. So that is why the constitutionally small fetuses has to be identified with the help of Dopplers and the biometric percentiles and help of Dopplers, and should be followed up and subjected to normal delivery, and the outcomes will be really good. And it is essential to understand that in India, the constitutional small fetuses with different India being a melting pot of different mix of ethnicities of Indo-European, Dravidian, Austro-Asiatic, and Tibeto-Burman. It is predominant. There is a significant small for gestational age fetuses born in this country, and it is essential for us to identify them. So I'm just summing up the Samrakshan Protocol 7, 8, and 9, the 2nd trimester comprehensive pregnancy scan with TIFA. It should include the screening for preeclampsia. 2nd trimester comprehensive pregnancy scan with TIFA and screening for fetal growth restriction with biometric percentiles, uterine mean PA percentiles, and umbilical artery PA percentile for the detection of early onset fetal growth restriction and identification of fetuses with fetal weight less than 10 centile with normal Dopplers. And it is essential for us to focus on the 10 to 30th centile of fetuses with AC bar with less whose AC and fetal weight is between the 10th to 30th centile. This is a group that can be significant overlap between developing fetal growth and restriction, and maybe a constitutionally small fetus also may be there. But we need to serially follow them up. And the 3rd trimester Doppler and anomaly scan, the growth assessment with biometric percentiles, and that with serial growth assessment with multi-vessel Dopplers, identify the early onset FGR, identify the SGA, late onset FGR, and the staging of FGR by the Barcelona classification, manage them accordingly. So these are the 9 protocols that I mentioned. What we knew is 8 to 10% of pregnant women in India develop preeclampsia, and there is a large percent of fetuses having fetal growth restriction. So the Samrakshan 7-star program was implemented with awareness campaigns, training, research publications, synergy with all stakeholders, including obstetricians, neonatologists, and policymakers, and all the paraclinical staff involved in motherhood, safe motherhood and childbirth and delivery. And the triple compliance, the Samrakshan policy documented was discussed with the health authorities, and we started a very ambitious campaign of Samrakshan 757 to extend the scope of Samrakshan to reduce preeclampsia to less than 10 centile in less than 10%, preeclampsia to less than 3%, and FGR to less than 10%. All in all the 757 districts of India by 2030. So This is a study that we published after 2 years results in the multicentric study of Samrakshan from 38 centers and 16 states in 2022. And this study clearly showed the first trimester screening where it was able to identify the PE in the low risk group was only 1.94%. That means that this has got the very high negative predictive value, and the high risk group which after low dose aspirin did not develop any complications, that is nearly 80%. We were able to we were able to avert preeclampsia in 80% cases, and the 20%, nearly 20%, the high risk group developed low dose preeclampsia in spite of low dose aspirin, because preeclampsia is a multifactorial disease. Similarly, if you extrapolate that result from FGR reduced from 100 to 30 lakhs, 1/3, and stage 1 FGR babies were identified and delivered up to term. Because there were some practices, once a stage 1 FGR baby was identified, everyone panics. But then we reassured the obstetrician and neonatologist not to deliver with because stage 1 FGR, the Barcelona protocol tells you to take it up to term and induce a labor. So we were able to convince them, and the stage 1 babies, FGR babies, were delivered at term. That started improving from 56% to 75%. So the incidence of preeclampsia reduced to 1/3, incidence of fetal growth restriction reduced to 1/3, incidence of preterm reduced to half. So this is a health economic analysis that was put forward. The cost of aspirin is 1 rupee per day, 175 rupees. And the managing preeclampsia ranges from 30,000 to 1,50,000. Depending on the places, it can be much more than that. But if you can avoid preeclampsia in nearly 16 lakh, 80% of 24 lakh of 24 lakh of high risk group, it is we're saving nearly 471 600 lakh Indian rupees. And the impact of FGR that I've already, impact of the color Doppler studies I've already mentioned on FGR. You see, similarly, preterm birth rates also showed a significant reduction. And this evidence-based program, the 14 publications in Indian Journal of Radiology and Imaging, there's a significant impact on preeclampsia, fetal growth restriction, and preterm birth and perinatal mortality rates. So if you look at the neonatal mortality rate, when we started, it was 29.5. It reduced to 9.86 if you take it from 2016 to 2022. 36 from perinatal mortality from 36 to 18, and from maternal mortality 113 to 58. Within a short span of 3 to 4 years, by implementing the Samrakshan protocols, we were able to show a significant reduction in neonatal mortality, perinatal mortality, and maternal mortality, which was really troubling this nation for the last 75 years. So we have showed up a way. But there is another condition that we need to seriously look into and change the protocols of Samrakshan, and when maybe more of Samrakshan protocols may be evolving in the future. This is a WHO UNICEF chart that shows the incidence of low birth weight babies all over the world. See that pink, this thing in India. India has got the highest this thing. More than 20% of the low birth weight babies all over the world are born in India. So it is high time for us to look into a new classification of small and vulnerable newborns. There is a new definition for improving the global newborn and maternal health. That is, they can be preterm. When we say small and vulnerable, it can include preterm, it can include small for gestational age, birth weight below 10 centile, which are, of course, and the low birth weight babies. But of course, in this group, the Dopplers are not being included, so that they will have a constitutionally small fetus as well as the true fetal growth restriction. The importance is these vulnerabilities account for more than half of all neonatal death, nearly 55.3%. And the babies born with these vulnerabilities are at increased risk of multitude of adverse health conditions throughout their lifespan. And if you look at the low birth weight incidence all over India, you will see more than 21% in some of the states like Maharashtra, Madhya Pradesh, Uttar Pradesh, Haryana, Punjab, and Orissa, and West Bengal, and Assam also. So, but even some of the states, if you look at none of the, only a few northeastern states show somewhere around 3 to 4. Rest of the states, including the southern states, are having 14 or 15 as the low birth weight. That's a significant number when you compare it. What is the significance of focusing on low birth weight? So whatever I discussed here are protocols. These are actually the protocols that we have implemented so far, and as we were working it out, and we were trying to have training programs, awareness programs, and implementation publications on that. But it needs to be a course correction here to focus on the small and vulnerable groups, vulnerable babies, because of this Barker's hypothesis, that is the fetal origins of adult disease. The one of the important point that I've highlighted is 75% of neonatal deaths and 50% of infant deaths occur among low birth weight infants. So the low birth weight babies has to be targeted. It has to be reduced. The incidence of low birth weight has to be reduced, not only because it contributes significantly to perinatal mortality, infant mortality, but also it has got a long-term implication in the development of adult onset diseases, the fetal origins of adult diseases like hypertension, coronary artery disease, stroke, diabetes, and metabolic syndrome. So that is how it is. There is a programming that is happening in fetal growth restriction fetuses and the neuroendocrine, pancreatic, skeletal muscle, adipose tissue level, and which is leading on to increased adiposity, insulin resistant, and future adult disease in terms of coronary artery disease, metabolic syndromes, diabetes, hypertension, and even chronic kidney disease, endocrine diseases. And that is why the second program that I've initiated and conceptualized, that is Preventive Radiology Initiative, IRA, is closely connected to the Samrakshan program. If we start targeting if we really want to target on the Preventive Radiology Initiative, that one of the focus that we need to give is a focus on the small and vulnerable group of babies, and how can we avoid low birth weight in India. So this is a talk that will be given by Dr. Amilu Varghese on August 29th. Can Samrakshan tackle the problem of low birth weight in India? And I just will wind it up with this slide, and that this is the Samrakshan studies that have come, and the 2023 results that I'm sharing it with you from 2019 to 23. It is now Samrakshan has been extended to 23 states, and we are having multicentric studies from more than 65 centers, 65 districts, and that shows the birth weight. If you look at the mean birth weight from when we started, it was 2.6 kg, that has improved to 2.8 kg. And the percentage of increase of babies more than 2,500 come from 67 to 83%. Even the birth weight between 2,000 to 2,400, it was 23%. It has reduced to 13%. So, so it is possible if you implement the Samrakshan protocol, focusing on the small and vulnerable baby. Before I wind up, this is the focus that we need to give for Samrakshan. What I've discussed so far is the Samrakshan protocols, but Samrakshan is not just protocols alone. It's a philosophy. It has got a practice, the way of practice to make a difference to the surrounding that you are doing, where you're practicing and you're living, to the fetal-maternal health. So it's time for us to concentrate on the vulnerable high-risk group of mothers. When we identify in the second trimester a fetal growth restriction or a fetal weight less than 30th centile or AC less than 30th centile, you have to look at the mother also, because malnutrition, anemia, especially can be a contributory cause for it, and it is time to work on it. Some of the results that we have seen, it's not just working alone on preeclampsia and FGR. Because once we have identified that high-risk group, more attention has been given to that particular category in terms of nutrition, in terms of medical management, in terms of the supportive care. So that also has made a significant difference in the outcomes. Again, I just wanted to highlight this. When you identify the vulnerable babies, there are different groups. Currently, with this, our protocols, we are focusing only on early onset fetal growth restriction, late onset fetal growth restriction, and small for gestation age. But there are 3 or 4 groups, 2 to 3 groups, which within that, which goes unnoticed, but it is time for us to focus on it. One I said, this is the small and vulnerable fetus that everybody knows. Early onset fetal growth restriction, late onset, and SGA becoming FGR. But there is a stressed fetuses. Their fetal weight may be more than 10 centile, but they may be having abnormal Dopplers. This is a typing error. It may be abnormal Dopplers. And there's a large for gestational age fetus with normal Dopplers, but it may be a stress fetus with metabolic acidosis. But there's another group, SGA with normal Dopplers, and which is nowadays with the help of Doppler, we can segregate this group. And there is another group in India, the small fetus with AC or fetal weight less than third centile with normal Dopplers for constitutionally small mothers too, which because as I mentioned earlier, we have got a significant variation in the constitutionality or the type in the constitution of the parents too. So it is essential for us to identify them rather than subjecting them with the parameter of less than third centile. Will always go for abnormality. It's essential to have a closer look at it. But if there are now a change in Dopplers, the parents are having constitutional this thing. It is time. We can give the leverage of taking them to the term also. So those are the issues of SGA, the possibility of crossing over to FGR. These are slides that I have borrowed from Dr. Anjali Gupta, our national coordinator. The risk of IUD is more in fetal weight or AC less than third centile, but taking up them to 36 or 37 weeks. And again, this group, the invisible group, the 10 to 50th percentile with abnormal Doppler needs special attention. But if proper special attention is given, the late onset FGRs with more than a 10th centile, because this is a group that has not been mentioned in the classic this thing of Delphi consensus or the Barcelona group. These are the groups that we identify very common in India, and we need to pay more attention to them. So it is time for us to give a focus. Protocols need to be developed for the small and vulnerable groups, the special groups that I mentioned, on their not only on their identification, but also on their management to reduce low birth weights, to have normal weights with normal neurologically intact babies without any adverse events, with normal outcomes. So if we really want to focus on that part, there will be more and more Samrakshan protocols that will be evolving, and I am sure you all will be contributing that towards our cause of reducing perinatal mortality in India, and also to avoid and to prevent the avoidable deaths of mothers and babies in India. Thank you very much for your kind attention.
Thank you so much, sir. That wonderful session. And each time we listen to you, there is always new learning and motivation, and you explore the new dimension and the various aspects of practice. So we are having few questions. Should we take here, or
I think we will take it later
at the end of
let Dr.
session?
Sandhya's present, because I exceeded my time. My apologies to Sandhya. But something that I wanted to share on these protocols, I think we'll introduce Sandhya and
Yes.
have her presentation.
For the next topic, preeclampsia and FGR screening, would like to call Dr. Sandhya ma'am. Ma'am is Director, Diagnostic and Fetal Center, Mohali and Chandigarh, and consultant radiologist and fetal medicine specialist with 23 years of experience in fetal imaging, and present affiliation, National Committee member of Preventive Radiology Program of IRIA, Samrakshan Initiative, Vice President of Chandigarh chapter of IRA for the year of 2020, member of Fetal Medicine Foundation, London, life member of IRIA, Indian Menopause Society and Society of Fetal Medicine of India, IFUMB, member of International Society of Obs and Gynae, and exclusive member of CRMS, and received certificate of honor for academic years 2020, 21, 22, and 23 for excellent work in radiology by IRIA for material services in Raksha Project, Samrakshan Project, Outreach Program, Shakti Project, and Preventive Radiology Committee of IRIA. Many paper and publication in IGRI, received first prize in paper presentation in AOCR 2018 in Mumbai, and award of excellence on Doctors Day by IMA in 2014. And received third prize for case presentation is your Mumbai, and received first prize and gold medal for paper presentation in ISKCON 2014. Many regional, national, and international presentations as faculty. Thank you so much, ma'am, for your academic enthusiasm, being with us, for your time. Over to you, ma'am.
Thank you, Akansha. I
Yes.
just share my presentation here.
Yes,
So,
ma'am.
is my screen visible?
Yes, full screen.
Yeah, thank you. So, for the audience, thank you for being with us at 10 p.m. at night. And it's always good to be giving webinars, but we don't get the audience interaction and reactions. So if you like our presentation, do send your messages in the chat box and claps in the chat box. That will encourage us to see your enthusiasm as well. So I thank Dr. Rijo for setting the platform for my presentation, because it may be repetition of many of the slides and about the preeclampsia and FGR, but I think it's worth mentioning again and again and focusing and about preeclampsia and FGR, which are the major problems in India today. So pregnancy-induced hypertension is among top 3 causes of maternal deaths in India. And if we look at the numbers and compare with the UK, we are way ahead in numbers, because the preeclampsia incidence is in India is about 8 to 10% in comparison to UK, which is 2.4%. And it is around 24 lakhs per year in India in comparison to 16,000 in UK. So the numbers are glaring and we need to tackle this problem. So the preeclampsia is a multisystem disorder of pregnancy previously defined by the onset of hypertension accompanied by significant proteinuria after 20 weeks of gestation. So why we are focusing in the first trimester if it presents in the 20 weeks of gestation? Because let me tell you, when we discuss about the pathophysiology of preeclampsia, it starts in the first trimester, and the trophoblastic formation ends by 20 weeks, and then it starts presenting in the mother. We need to focus on the early period of gestation so that we can prevent preeclampsia, because we are not focusing on the treatment, we are focusing on the prevention part of hypertension. So it presents in the form of high blood pressure, urine in protein to creatinine ratio of more than 3, and dysfunction of other organs like liver, kidneys, lungs, and brain, leading to preeclampsia syndrome and also HELP syndrome. So to avoid this, we need to discuss something more. What are the subtypes? So it can be an early onset PE when the delivery happens before 34 weeks. It can be late onset PE when delivery is at or after 34 weeks, and it can be preterm PE or term PE. So basically, we need to understand, according to the phenotypes, the preeclampsia can be preterm and term preeclampsia. Preterm, when it is less than 37 weeks, it presents. And it is basically a placental dysfunction in the preterm preeclampsia. And there can be placental volume, which is reduced, which leads to fetal growth restriction, abnormal umbilical and uterine artery evaluation, low birth weight, and adverse maternal and neonatal outcomes. In cases of term preeclampsia, usually it is the maternal disorder and the placenta is almost normal or maybe larger, and the fetus is also looks normal with normal Dopplers, but mother can be affected, and sometimes, many of the times, it is the normal outcomes of the neonates. So whenever we talk about the first trimester screening, the thing which comes to our mind is the NT scan and the Down syndrome screening. But let me tell you, we are not focusing on the larger problem in the room, which is the preeclampsia. Because if you look at the incidence, the Down syndrome is around 1 in 1,000, whereas the preeclampsia is 100 in 1,000, which is way ahead of the Down syndrome. Secondly, Down syndrome is a chromosomal abnormality which cannot get treated or prevented, but preeclampsia is preventable. So we need to focus on the thing which we can prevent. Another important part to it is that there are 2 lives which are at stake. that is fetus as well as the mother. So there are many maternal complications as highlighted by Dr. Rijo also, and the severe form can lead to even brain injury and death in the mother. As well as in the fetus, there are short-term complications starting from fetal growth restriction, intrauterine fetal death, and need for the NICU admission because of the low birth weight. Whereas the long-term complications include the cerebral palsy, low IQ, and even diabetes and coronary artery diseases in the later part of their life. So we have so many things at stake when we talk about the preeclampsia. And there is an overall increase in the perinatal and neonatal mortality rate. Now, what should be done? We understand there is a big problem and we can prevent preeclampsia. We need to understand what is the universal screening protocol and how we are doing it with the Samrakshan protocol. As you can see, there are a lot of research and papers published about the preeclampsia starting from 1980 till 2020-23. And different guidelines and different publications have come up. And there are different people who have worked for preeclampsia. And this is the Pune et al. In 2010, which gave that if you include the maternal factors, maternal arterial pressure, mean arterial pressure, and uterine PI, you can get a detection rate of approximately 84.6. And we are also working on that in the Samrakshan protocol. For the pathophysiology, we need to understand that preeclampsia is generally understood to be an immunological inflammatory condition that involves the process of placentation, but the underlying causes, precipitating factors, and conditions are not fully understood. So what happens exactly is that normally the spiral arteries, when they form, they are very tortuous and dilated. But in cases of preeclampsia, the tortuosity is less and trophoblastic invasion is also impaired, leading to placental hypoxia, release of trophoblastic factors into the maternal circulation, and platelet and endothelial cell activation and damage, which leads to clinical symptoms of preeclampsia in the form of high blood pressure and urine proteins. So what we need to see here is the uterine artery Doppler to look at the uterine artery PI, PLGF as a marker or biochemical marker in the maternal blood, and mean arterial pressure to look for the symptoms of preeclampsia. And if we combine all these factors, we can have a very high sensitivity for the detection of preeclampsia and FGR. So many of you must be thinking that we are already doing uterine artery Doppler. What's new into it? But are you actually calculating the preeclampsia risk for that particular lady when you are doing a uterine artery Doppler? I don't think 80% of you are doing that. So when we talk about uterine artery Doppler as a standalone marker, the detection rate is only 47% for early PE.
Is there a connectivity issue or?
Yes, sir. That call in one.
Yeah.
Ma'am will be joining us soon. Some connectivity problem. So we can take the questions, sir. Meanwhile. Okay, ma'am is there. Ma'am, we are not getting your voice.
Sandhya, if you can, if your video can be off, the voice will be better. When the connectivity is less, that's a usual thing. I think,
I'm just.
yeah, you have to inform her because it's not audible.
हाँ, वॉइस नहीं आ रहा था, आपने चालू किया था? No. Shreyasi, please unmute ma'am. Na, ma'am is not able to unmute herself. Shreyasi? Hello?
Yes, ma'am.
Ma'am is not able to unmute herself, na?
Oh, okay, ma'am. All I can do is I can send her a request to unmute, but she needs to accept that.
Okay. Ma'am, I think it's from your side.
Can't hear anything. Not audible. Not audible. Session not audible.
Yeah, there seems to be a connectivity issue from the side of Dr. Sandhya. We are trying to sort this out.
Okay. How long it will take?
Should be sorted out soon. Agancha,
Yes, sir.
if there is an issue in connectivity, why don't we have that session in the next next week?
Yes. Yes, sir, we can continue
Yeah.
with that.
And we will conclude this with after taking a few questions today.
Yes, sir. Yes. Questions.
Okay.
Is it possible for a fetus to come out FGR? Suppose if on previous scan AC was at 5th centile and on the subsequent scan it crosses 10th centile. Is it a technical error?
AC increasing.
Yeah, improve.
Yeah, I think there are few things that has to be discussed here regarding the biometry assessment. The AC assessment has to be proper where the compressed abdomen parts need to be calculated. In the sense, many a times we have seen that the AC measurements that has been taken is not proper, either due to the fetal position or due to the caliper placement or due to the technique itself. That is one thing that has to be looked into. But if it is in 28 to early third trimester, we can see an increase in abdominal circumference of the maternal malnutrition, and factors like that has been taken care of. But generally, again, I do want to emphasize the point that it is not a single parameter that we are looking at. It's a multi-parametric assessment, not only the biometric percentiles and the Dopplers and the change serial growth assessment. All these three parameters has to take into consideration if we want to diagnose cases of FGR FGR, and to differentiate the small for gestational fetuses. So it should not be. There can be changes, but that depends on whether you have to reconfirm whether the biometric measurements were done properly, whether the fetal the section was proper, and the caliper placement was proper. And there can be an increase in AC if it is in the 28 to this thing with sufficient taken care of the maternal malnutrition and other parameters.
Patient at anomaly scan is normal centile weight, and then they directly come at 36 and 37 weeks with less than 10 centile. So how to go about this?
You have to do the
early onset or late onset?
You have to do the Doppler. You don't just rely on the EFW of less than 10 centile. We've already discussed. If the problem is we are still doing some old practices, just do a BPP, just a growth scan. It is time for us to discard all those things. It has to be multi-parametric assessment with biometric percentiles in your the serial growth assessments and the Doppler percentiles. So without that, you may not be in a position to give a proper assessment of fetal growth restriction, SGA, and identify the small and vulnerable babies. So I think Sandhya, you're back.
Yes, sir.
Yeah. Would you like to continue and finish off the session, or do we want?
Yes,
I
sir.
think since you are back here, we'll continue the session and
Yes,
complete it. Okay. Please go ahead.
Okay.
I think Sandhya's talk is most sought after because nearly 100 people are still waiting in spite of the technical glitches.
Thank
so
you, sir.
Sandhya, you have to continue.
So, as we do combined screening for Down syndrome, we need to do a combined screening for preeclampsia also. In this, what we include is the maternal demographic factors, that is the maternal history, and then the mean arterial pressure, that is the maternal blood pressure. And then we do the uterine artery Doppler and the biochemical markers, that is PEPI and PLGF. So if we combine all of them, we get a sensitivity of approximately 90%. A lot of papers published about the sensitivity and the markers, and we come to the conclusion that this is the best method to do it. Then there was a NICE guidelines and ACOG guidelines, which tells you to start the low dose aspirin of approximately 75 milligram, but they found out that the efficacy of this for prevention of the preeclampsia was very, very low. And then comes this ESPRIT trial, which tells you that if we increase the dose to 150 milligram per day at night from 12 weeks to 36 weeks, we can reduce the onset of preeclampsia in the mother, and it has got a very good efficacy. And this is the FIGO guidelines, which says that 150 milligram of aspirin to be taken every night until either 36 weeks of gestation till the delivery for the best outcomes. And can we start with this aspirin to all the pregnant women? But the answer is no, because it has its own complications like the peptic ulcer and gastritis and bleeding disorders. So only the high-risk women should be given the aspirin, not all pregnant women. Now, in 2022, this is a combined of all the different studies has been done. And this says that the FMF triple test, that is the maternal characteristics plus maternal arterial pressure, uterine artery PI, and the serum PLGF, gives you a detection rate of 90% to 75% with a false positive rate of 10%. And this also has been shown that if you take only the maternal factors into consideration, you get a sensitivity of 53%. If the maternal arterial pressure, you get 61%. And if you include the maternal factor map, mean arterial pressure and uterine PI is 83%. And if you do combined with the biochemical screening, then you get a 90% results. So in Samrakshan protocol, we are focusing on at least all these three parameters if we avoid the biochemical markers as well to get at least 83% of a sensitivity for the detection of preeclampsia and FGR in the first trimester. So this is the proposed screening and management during pregnancy. As Dr. Rijo has also mentioned that we need to focus not only in the first trimester, but also in the second and the third trimester. So screen your patients, all pregnant women, about all these factors, calculate the high risk or the low risk they fall into, and then reassess all pregnant women in the second trimester between 19 to 24, and again categorize them for the high risk and low risk. And you can add biochemical markers if your patients allow it, but if it's a low strata population, you can avoid the biochemical markers and you get a very good sensitivity of 83% also for your patients. So this is what we talked about, the universal screening of preeclampsia. Now we need to focus on the pregnancy care in India and what we can do best in Indian scenarios. So as you know, we deal with two kind of population here. One is urban and one is rural, and rural constitute approximately 80 to 90% of Indian population. And the facilities which we get, we need to, do whatever possible best in all those facilities. So Samrakshan protocol is for the Indian woman, and it is designed for Indian women. And what we are doing in this is focusing on two main preventable causes, that is hypertension and fetal growth restriction, which leads to preeclampsia and main causes of maternal mortality and perinatal mortalities. So this program we have been running since 2019 and got good results, as Dr. Rijo has also mentioned. So our focus of Samrakshan is of 757 is to reduce the preeclampsia to less than 3% and FGR to less than 10% in 757 districts of India. And we want to apply it nationwide for effective first trimester screening with the FMF algorithm, and even in the third trimester screening for early diagnosis of FGR and timely delivery, what is required. So this was started by Dr. Rijo Mathew sir and Dr. Parveen Nirmalan sir, and we all are just following their footsteps and getting good results all over India. So we formed the Samrakshan teams, Samrakshan protocol. We have done a lot of CMEs and webinars, live workshops, one-to-one discussions. And in all the states and districts and cities, we formed the Samrakshan Yodhas, and Yodhas are doing wonderful work by telling other radiologists to join this and to do wonderful work, which everyone is doing at present. We have also done the Global South Alliance for Safe Motherhood, and this is where we are going globally, and this was also founded by Dr. Rijo Mathew. And this decentralized Global South collaboration aims to integrate all stakeholders in maternal and perinatal care with focus on maternal environment and fetal growth, along with comprehensive and protocol-based assessment of pregnancy scans. So how we do it in Samrakshan Bay is the most important part of my presentation. We give a unique ID to the patient. We take the history, that is personal, past, family, and medical history. Then the blood pressure of the woman is taken, minimum 2 readings in each arm. We do the ultrasound examination as in the first trimester. Most of the time we do the detailed first trimester scan, including the NT, and the uterine artery Dopplers are always included into it. We calculate the risk with the FMF software to see whether they are falling into high risk or the low risk group. Then the counseling and recommendation is the part of our scans, and we ask them to follow up in the second trimester. These forms are available in our website, that is iri.org.in, where the Samrakshan forms are there. So you log into IRI and a pop-up window will come where you can see the Samrakshan forms. You click on the Samrakshan forms and you can get these forms of the first trimester, second trimester, and the third trimester. Either you can take out the printout of these Samrakshan forms, or you can directly fill all these findings into the online forms. So this is a form of the first trimester for preeclampsia and FGR, in which, if you can see, there is an email ID which the doctor has to fill of their own ID. That scan ID is the patient ID, the unique number which we assign, the month and the year, the district and the state. Then date of birth of the patient, date of examination, gestation age at exam, number of fetus, height, weight, racial origin, smoking, if there is any significant family history, type of conception, hypertension, diabetes, SLE, and APLS. And then you take the blood pressure on both the arms. Both the readings are written here. Then you take the uterine artery, and then you mention if it is twins, then CRL of 1 and CRL of 2. Small, if there is any previous pregnancy, what was the gestation and what was the weight of the baby. And then you calculate the risk for preeclampsia and FGR as well. And then you recommend according to if the patient fits into high-risk group as low-dose aspirin, whether it was recommended or not. The cutoff for the high risk is 1:150, and for the FGR also it is 1:150. So this is how the forms are filled. And each thing, whatever it is written here, whether it is SLE or it's chronic hypertension, is a very important marker, because these are all, one thing becomes positive, the risk of the mother goes high and it falls into the high risk category. So you need to train your staff. Whosoever are filling the F form, you can just tell them to fill this form, and this work can be done by your staff. Then every Yodha gets the Excel sheet in this form as the Yodha Excel sheet, in which you can put all the patients' IDs, name, age, as, and all the risk factor, which can be filled later. Maybe when the day ends, you can fill up all the forms into this and send it to. Why we are talking about filling forms and sending it to online to the Samrakshan team? Because if you are doing good work in your own center, you are helping your patients. But if you are sending these forms to the Samrakshan team, you're helping the whole nation. As we get Indian data, we compile that data, we strategize on the basis of that data, and we also tell you whether your patients are improving, what is the cutoffs for the uterine artery for the Indian data. Just for example, this is the data compiled for 3 years, and in this we have found that our uterine artery PI indices are slightly different from the global PI indices. And as you can see, in between 11 to 13 weeks, the 95th percentile, which we take as a cutoff for the Indian data, is 2.7, whereas for the global, it is around 2.3 to 2.5. So we are also different. And if we can get our data for our population, that will help us in making strategizing our policies in future. So each risk factor, as I told you, is very important. A raised BMI, a pre-existing hypertension will make your patient in the high-risk category. So it's not only the high PI of the uterine arteries, it's even the weight of the patient, the height of the patient, the history of smoking, the history of antiphospholipid syndrome. All this makes your patient into a high-risk category. So if only uterine artery will not help you in making it a high-risk group or a low-risk group for that pregnant woman. So even if you are thinking that you are doing the good work by just telling them the high mean PI of the uterine artery, it is not. So this is just a few small video of how we are doing it in our center. So this is, we have trained our staff So when the patient comes to the reception, we take it to the history room where history taking and the height, weight, and the BP monitoring of the patient is done. These are the same staff who fill our F forms, and they, along with this F form, we have kept the Samrakshan forms for all the trimesters so that that form can also be filled. And we have taught them the right way of taking the blood pressure of the mother and how it should be taken. And it is easily can be done in your center also. And then this patient goes to the ultrasound room where we do the anti-scan. And along with the anti-scan, we map the uterine arteries on both sides of the uterus and document it in the record. And this whole data and the form goes to the person who makes the final report of the patient. And there we have the online free FMF calculator for calculating the risk for this pregnancy for PE and FGR. And then the final report is made and recommendations are written at the end of the report about the whether the patient should start with the low-dose aspirin at a bedtime or not. So these are the guidelines for blood pressure measurement. We use the automated devices, and the patient should be comfortably sitting on the chair and the legs should not be crossed. Arm should be supported at the level of the heart. 2 readings for each arm are taken at a gap of 5 minutes, and the cuff size, as you can see in these pictures, it should be according to the mid-arm. They say that both the arms should be simultaneously recorded, but if you have a single automated machine, at least take one by one after a gap, but do measurements in both the arms. So why mean arterial pressure? Why cannot we just write the systolic and the diastolic pressure? Because it has been seen that the accuracy of the mean arterial pressure is better, and it is a better indicator for preeclampsia. So this is how the FMF online calculator will appear if you put the FMF fetalmedicine.org, and this is the preeclampsia which will come for the 11 to 14 weeks, and you click on this, the window will pop up like this, and you can fill your blood pressure measurements on both the arms, 2 measurements, and then you can calculate the mean arterial pressure. Coming to uterine arteries, why we need a standardized protocol to map the uterine arteries so that there are no differences or inter-observer or intra-observer differences between the uterine artery PI. So we all must stick to one particular method of taking the uterine arteries and not just do in my own way. So there are SWOG guidelines, there are FMF guidelines, and there are Samrakshan guidelines too for us to understand this. As you know, uterine artery is a branch of the internal iliac artery, so we need to go to the cervical region, focus the cervical region, then just tilt your probe towards the right side and put your color box. See the vessel where it is crossing the iliac artery. Zoom your image for better visualization. You can scale down your velocity, and you can increase the color gain to see the vessel more carefully. And then take the uterine artery. See to it that your gate is around, sample volume is around 1 centimeter crossing over. The gate is small. Angle of insonation should be less than 30 degrees. And the peak systolic velocity should be more than 60 centimeter per second to tell you that you are not mapping any of the branches of the uterine arteries, but only the uterine artery, which is important. You can do it even by the transvaginal route also when you're doing the cervical screening in the first trimester. And the method is the same. You go into one of the fornices on the right or the left, and then see the uterine artery there, crossing the iliac artery, and you map it there. But you have to keep it in mind that as the probe is near to the cervical region and the uterine artery, the values of the uterine artery PI could be higher in the transvaginal scan, and that is why the cutoffs are placed a slightly higher as 3.2 sometimes. But as such, we try to take it by the transabdominal route only. Now, the good practice points are also there that the bladder should not be over-distended or overfilled. It may change your values. And you can also take uterine artery in the transverse scan by looking at the vessels on both sides of the cervix sometimes if you are not able to do it by the longitudinal or sagittal way. And do not put a lot of pressure. It will rather make it more difficult. Decrease PRF if you are not able to see the vessel. Angle correction has an important role to play. And the peak systolic velocity should be always more than 60 centimeter per second. So another question comes into mind why we only talk about the PI values whenever we talk about even the fetal Dopplers, because PI is a better predictor. And why it is so? Because it is the average values of all calculation. It is the systolic volume minus diastolic volume divided by the mean volume. And it is a more stable number and does not reach infinity when there is absent or reverse diastolic value. So even if you get a absent diastolic value, you will still get a PI value. We must know what are the normal waveforms of the uterine arteries in different trimesters. So as you can see here, as the trimester, we start from first to third, the diastolic flow increases, and a diastolic notch also we have to keep in mind. In the first trimester, it can be just normal to have a diastolic notch. If we don't mention it also in our report, but if you see a diastolic notch in the third trimester, you need to mention it. It has got an importance to it. So now you got your mean arterial pressure, and now it's the time to put your mean uterine artery PI. So you click on this window, you put left and right PI of the uterine artery, and you calculate the mean PI. And if you have done the biochemical, you can put your values into it. If you're not done, you're not bothered, you can directly go and calculate the risk for that particular pregnancy. So just to mention about what are the biochemical markers, these are the placental growth factors, soluble FMS like tyrosine kinase, also known as SFLT1. Then there is SFLT to PLGF ratio, which helps to predict the outcome in the second trimester. And then a PP3, that is the placental protein 13, which is seen to be helpful in the third trimester. We'll not talk much about it, but we understand now that with only maternal demographics, uterine artery mean PI, and mean arterial pressure findings, we get a sensitivity of detection of PE and FGR to up to 80 to 83%, which is a good sensitivity. If we add the biochemical markers, you can get a sensitivity of 90%. So now you calculate the risk and you see how your patient is falling into, whether it's into a high risk category or low risk category. That is, a risk less than 1:150 is the high risk category. And aspirin is started in these patients. And we tell them to take this aspirin at bedtime because it has been seen that the efficacy of the treatment is more if they take it at the bedtime. And at least we get a more than 90% compliance in such patients. And the low risk group can go for the reassessment at 22 weeks. And again, the same method is now then taken for their assessment, and further action can be done. So a few examples which we have done. It's a 27-year-old primate with the weight of 62 kg, height is 163 centimeter, but MAP is 92. And GA by LMP is 12 weeks, 3 days, and GA by ultrasound is 12 weeks, 4 days, which is corresponding with the dates. So dating of the pregnancy in the first trimester becomes very, very important and should always be done in a correct way. So average uterine artery PI in this case was in 1.98, which was 77th percentile. And the risk calculated for this patient was P87 and risk for FGR was 99. So it is less than 1:150, so falls into the high risk group. So although the uterine artery PI, as you can see here, is only at 77th percentile, but because of the demographic parameters and MAP, which is falling into the high risk category. So according to this, we have recommended her for aspirin 150 milligram and at night. And the patient started with this, and she was called at 20 weeks for a level 2 scan in the second trimester. And as you can see here, at the 20 weeks, her AC is at 36 percentile and EFW is 34 percentile. The uterine artery PI is also at 91 percentile, so more than 90 percentile. Although everything looks fine for this, and she's still continuing with that, you look at the growth graphs, and the graphs are pretty okay, but they're falling in a falling trend, the growth velocity curve. So in the third trimester at 30 weeks, the AC is fallen down to 6.8% and the weight is at 7.8 percentile. Look at the uterine artery, it is still at more than 90 percentile. Although the umbilical and the MCI here are normal and CPR are normal, so rest of the parameters normal, we gave them the go-ahead to continue further with the close surveillance, although it was looking like a SGA fetus with normal Dopplers. So follow-up was done after 15 days. And in the third trimester, the patient showed that the PI of the uterine now have become more than 95th percentile. As you can see here, the AC has fallen down to 1.9 percentile, although the Doppler is still normal. So it has now become the late FGR, and the LSCS was done at 37 weeks with a female fetus of around 2,000 grams. So with this, what we understand that because the aspirin was started at the right time, the development of preeclampsia or the development of FGR was late, and we could have a normal baby at the end of the day. This is another case. This is a 29-year-old female with 157 centimeter of height and weight is 55 with a mean arterial pressure of 72. CRL was corresponding, but the uterine artery average PI was very high. This is more than 99 percentile. The risk calculated for this patient was again high risk with the PE at 103 and FGR risk was 29, which is very, very high. So we asked her to start with the aspirin at night, 150 milligram, but patient did not listen to us and not started with any of the treatment. She came back to us at 20 weeks with MAP of 79, and they look at the uterine artery PI. It is still more than 95 percentile, with AC now at 11 percentile in the second trimester at 20 weeks, and the fetal weight is only 5.9 percentile. So this is an early onset of FGR with the high uterine PI and weight less than, it's at 5.9 percentile. She came back to us at 29 week, where we can see that along with the weight, which is now at less than 1 percentile, AC less than 1 percentile, the uterine artery high, and the BP is also now touching 150, with the MC at 4 percentile and umbilical artery showing absent end diastolic flow, and there is a reversal in the aortic isthmus, which is also not a good sign for the baby. And DV is also now touching the 90th percentile with the stage 2 FGR. Then we called her back after 1 week that how she's doing. Then she told us that there is an IOD and they lost their baby. So it sends us a great message that by just adding one simple aspirin to the treatment of the patient, it makes a hell of a difference. And now this is our data about how the Indian scenario of perinatal mortality will change if all of you start with the PE and FGR screening in your day-to-day practice. That we have a total pregnancies per year is around 30 millions. And out of this, if 8%, that is the risk for the preeclampsia, is around 24 lakhs can develop. So if we do this PE screening of these 24 lakh patients, including the all the three parameters which we just discussed, we can benefit 20 lakh of patient. And if they start with the aspirin and even 80% shows the compliance, that then 16 lakh of these women can get benefit from your treatment and from your work. And this is our reports which we have done, which shows that preeclampsia averted by Samrakshan Protocol, and 15.72 lakh women got benefited from this. This is another paper which tells you about the effectiveness of first trimester Samrakshan Protocol for the identification of pregnant women at high risk for preterm preeclampsia. And in this protocol, we found that all these three parameters are combined together. It gives a high specificity of 90% for the detection of preterm PE in the Indian population if it is done properly. So these are the Samrakshan results of 2019 to 2023, that with the strength of the Samrakshan Yodha increasing, we see a decline in the early neonatal deaths from 2019 to 23. And this is that the incidence of preeclampsia is reduced from 24 lakhs to 5.5 lakhs in the 2023 as the strength of the Yodhas increased from these 3 years. Initially, they were only a small group of people of approximately 40 radiologists who were doing the scan. Now we are almost gone to 400 to 500 radiologists who are following the Samrakshan protocol. So if we can make a change, you can also do it. So to conclude, I would say that the preeclampsia screening is need of the hour to improve maternal mortality and perinatal mortality rate in India. Algorithmic approach and stratification for proper training should be done to improve the detection of preeclampsia. Do at least history, maternal arterial pressure, and uterine artery Doppler in the proper way and calculate the risk, which will give you a detection rate of 80%. Ensure that the high-risk patient should start with the low-dose aspirin and should be followed for their outcome. As we train our staff to call back our patients and take how they are doing, you can also do that, and it will make a difference in your practice. Join Mission Samrakshan to give you a little bit to the society to bring the change. And join Pan-India movement of Samrakshan for safe motherhood and safe child. Thank you so much for your patient hearing and waiting with us to join Samrakshan. Thank you so much.
Thank you, ma'am. Wonderful and very enlightening session, and must be very helpful for everyone.
Yeah.
Yes, any questions further? Yes, Anjali ma'am is there with us.
Thank you so much, ma'am. That was a very beautifully explained lecture, and we had so many questions in our chat box regarding how to do first trimester screening. So I hope your session has answered everything. If anybody still has questions for Dr. Rijo or Sandhya ma'am, please unmute yourself and ask live. These are interactive sessions. You can always unmute and ask your question directly rather than putting it up in the chat box. It would break the monotony, and we would love to hear the voices.
I think Anjali has answered most of the questions in the chat box.
I think I will. If some questions have been missed, you can directly ask. So for the next,
I think Anjali, some of these questions are can be taken up in the subsequent sessions where now we have understood what are the kind of doubts. So a lot of questions I can see here. And you've answered most of them, but these are the kind of doubts most of the viewers have it, most of the practitioners have it, and I recommend to have a FAQ kind of session or a FAQ kind of material that can be circulated based on the common questions asked. Thank you.
So there is a question about what protocol, FMF or Barcelona. So for calculating preeclampsia risk, I think FMF we are using. For FGR, we are using Barcelona.
Yeah.
Right?
So for the next 2 months or so, we'll be focusing on fetal growth restriction, fetal risk, FMF, PE, and FGR risk estimation, and comprehensive scanning protocols in each trimester. So we'll be what we propose is that you equip your clinic for giving risks. You buy a BP instrument, buy 2 BP instruments, buy a weighing scale, put up a height chart in your OPDs, and give your OPD staff, the girl or the nurse who's filling up the forms, the Samrakshan, the FM form Fs for your PND. The same staff can take up history. So you have to give them a proforma in printed proforma, where simultaneously she can ask for basic history and start filling at least 1 or 2 forms every day. So start giving risks to NTNP scans, at least 2 per day. So in 15 days, you'll be able to know whatever doubts you have. And after 15 days, we can have a similar FAQ session after the second trimester risk session. And then we can answer your queries. And once you start by doing 1 or 2 cases per day, the inhibition or the hitch you have in giving the risk will get away, and then you'll start slowly start realizing the impact it can have on the overall practice. So this is what we recommend, and we are there to answer all doubts after each Friday session. What if any other doubt you have, you can please unmute yourself and ask from the speakers. They're all here today. So I think I've answered most of them.
I think some of the doubts can be based on the sometimes the MAP is normal, uterine artery PA. So in spite of that, we got high risk, or some of them are maybe people consider that they are normal, but it's not like that. That is regarding the construction of that online calculator. The weightages has been given to several parameters, and the reason sometimes the combined screening may have a low score in spite of having a uterine PI on the 95th centile is because that everything put together, the weightages, everything put together, it may not come into that cutoff range. But still, again, those mothers should be followed up in the second trimester. So these kind of doubts we have seen in many groups where Samrakshan usually used to have the state groups in the initial years. And these are the usual doubts when they fill up the form, when they see that because most of them are having the impression uterine artery PA percentile is the ultimate thing. But combined evaluation has got maybe giving a lower risk or maybe giving a borderline thing. So what to do next? So there are a lot of questions regarding all these things. I think we will have an entire compile all these questions and may have a question frequently asked questions and answer sessions later. Thank you.
Thank you, everyone.
Yes, and please requesting everyone join the FGR Quiet India movement, and you can write here. I am sharing in the chat box about your views, poems, and all. And please be the part of movement. It is very, very interesting to know the so many as like last month we have this preeclampsia awareness movement. So many inputs we have got in the in Instagram link of the Samrakshan itself. So we will be sharing all those in that page also. And next in the webinar series, the discussion will be ophthalmic artery Doppler panel discussion. on 16th of the August. Dr. Lalit Sharma, the past Samrakshan National Coordinator from Guna, will be there with us. Dr. Kavita Aneja ma'am, National Core Committee member, and Dr. Soumya Dwivedi, Samrakshan Yodha from Bhopal, will be joining us in that discussion. Usually clash.
There's a doubt that since patients come to us for USG, they are referred to us for USG. How can we prescribe aspirin? It may clash with the referring doctor.
So what we do actually
Common,
is,
common.
we just recommend, because she falls into high risk group, we recommend to start aspirin at bedtime, 150 milligram. And we also inform the gynecologist, the treating person who is there. So maybe you are not prescribing, you are suggesting, and you are telling them to start. And we inform them about it.
That makes
So
sense.
don't worry about it. Over a period of time, your obstetrician will get convinced. And
Yeah, you need to tell them.
Yeah,
Yes.
the initial resistance may be there for some, but those who have given the low dose aspirin and seen the results, they will the resistance will come down, and they will immediately start, because it delays the onset of preterm preeclampsia, the FGR. So they will start seeing it over a period of time. This is what has happened all these 5 years. We have seen great resistance in the initial phases, but everything has come down, and they have become a great partners in this campaign.
I think
we can. Another request. Samrakshan quiz number 15 is open, and please attempt these questions. Very interestingly, they are designed, and sharing the link in the chat box. Please go and after the session try to attempt these quizzes. And after the second part, we will announce again with 20 question, the winner of these quiz.
So this regarding the quiz, I must congratulate Anjali and Agansha for the effort that you have taken. Now that is nearly 15 quizzes every week. That quizzes are really a good learning experience of different conditions, and including Samrakshan topics have been the focus on preeclampsia, FGR, and not only, and other anomalies and aneuploidies being covered, the comprehensive assessment being covered. Hats off to you, Anjali and Agansha, for the wonderful effort that you're taking. But we need to get them into the residents and the young radiologists and the practitioners, so that more and more people will get into that learning process. So wonderful work that you have done should be really rewarded in that way. We need to circulate it in our social media groups, as well as emails and Gmails. Emails, we need to reach out to most of them. I think the link given here, if you can look at from the ClearNet side, to send us a mail to all the participants, that will be better, rather than putting it here, which may not be able to copy it down or may not do. It is possible for ClearNet to send that quiz through the email. That will be ideal.
Yes.
And I will request all the participants, if you have any queries or if you want to start the Samrakshan protocol in your center, do not hesitate to, call any one of us. You can always directly give us a call, understand how we do it, and get even training for about it. And you want your staff to get trained, that can also be done.
So I think it is time to wind up.
Yeah. So would like to thank Dr. Rijo Mathew sir, founder IRIA Samrakshan Initiative, Dr. Hemant Patel sir, founding patron IRIA Samrakshan, Dr. Amarnath sir, founding patron IRIA Preventive Radiology, Dr. Vara Prasad sir, National President IRIA, Dr. Murli Krishnan sir, Secretary General IRIA, Dr. Praveen Nirmalan sir, Chief Research Mentor of Samrakshan Initiative, Dr. Anjali ma'am, National Samrakshan Coordinator, all the attendees, Dr. Rijo sir, Speaker of the Day today, and we are always being inspired by your all the talks. They are very encouraging, and we always get to learn new things every time, sir, from that. And thank you so much, Sandhya ma'am, for efforts and being with us as a Samrakshan Yodha, always guiding us for all the queries and especially those form filling things, Excel sheet. We are having large number of the entries from your area under your guidance, and thanking everyone, all the attendees being with us, and hope to meet you all next time, starting the Samrakshan protocol in your clinical practice and knowing more the queries and doubts, and would like to take all it further. And thank you so much, Team Clarinet, being with us, giving the seamless experience for these clinical needs. Thank you, everyone.
Thank you,
Thank you.
Akanksha, for being
Thank
back.
you,
Thank you,
Akansha.
Akansha. Thank you, Anjali.
and
Thank you,
Rijo.
Sandhya.
Always
Thank
good
you,
to
sir.
have
So
you. Good
it's
night, sir.
already 11 o'clock now.
Yeah.
Yes, yes.
Okay, good night.
Good
See you.
night.
Good night.
Good night.
Thank you, Sandhya ma'am. Good night. Good night, sir.